Good morning, everyone. Well, thank you, organizers, for this opportunity. Well, I'm going to do a talk on diplopia with vision loss. And I'm a neuro-ophthalmologist, so obviously no financial interest. So diplopia with vision loss don't go together. So if you see a patient with diplopia and he's going to walk in after a while that my diplopia is gone and I'm having a no diplopia, well, that's not a good sign. So that's something which you have to watch out in a short interval, a diplopia vanishing off in a patient. So I asked Rashmin, what should I cover? This is not a very comfortable topic. He said, just start exploring the no man's land, orbital apex. So this is my topic today. So what are the warning signs for these serious issues? It can harbor serious systemic diseases like joint cell arthritis, many orbital pathologies like thyroid eye disease with IIOID or myositis. My previous speakers have narrated few of them. Well, let me restrict to my talk to orbital apex. So although this is the anatomical landmark what we are going to discuss in this talk, orbital apex, superior orbital fissure, cavernous sinus syndrome, well, these are not miles apart. So any lesion which starts in one is easily going to slip into the other, and what you see in the radiological feature is something sitting across the orbital apex to the orbit to the cavernous sinus, something like this. So anytime a lesion, it might take even days to hours for a lesion from one segment to move on to the next. So you have to really be very fast in acting in such lesions. So orbital apex refers to the multiple cranial nerve palsies with or without optic neuropathy. So it can be also isolated at times with vision loss, and this is the classification what is being textbook described, where you have a superior orbital fissure involving 3, 4, V1 and 6, and that of an optic nerve dysfunction is the orbital apex, and that of a V2 with an oculosympathomimetic is the cavernous sinus syndrome. So these are the list of causes which I may not go into. These are the common ones which we encounter in our clinical practice, starting from inflammation to mass lesion to infection to vascular lesions and post-traumatic or unfortunately after few iatrogenic ENT surgeries. So how do you evaluate such a patient? Just like how you go about doing a diplopia evaluation, go for a detailed history taking, systemic illness, and watch for associated signs like proptosis, squint, ptosis, vision loss. All these are going to matter a lot, and do not forget to perform an optic nerve function test in such patients who are walking in even with diplopia of whatever type, horizontal, vertical, or whatever. Do perform a complete optic nerve function test, because that's what is going to guide us, not missing this group of diseases. So there are some adjunct tests like OCT, but visual field is mandatory. And MRI brain and orbit is the preferred neuroimaging of choice, particularly thin cuts, fat suppressed, post contrast, if preferable a 3 Tesla, but 1.52 will always do better, but with a flare and a stir sequences, and a fiesta probably in a cranial nerve palsy. And CT has a very limited role, maybe after post-traumatic fractures, meningiomas, or to decipher the bony details, particularly in diseases like pneumosinus dilatans or fibrous dysplasia. So this is the algorithm what we follow for the orbital apex. If you find, the first thing is go ahead, get an imaging simultaneously, and if there is a history of trauma or surgery, rule out an infection, because we are going to, next step is plan for a steroid therapy. And if there is a complete no possibility of infection, you can move on with steroids. And if it's a mass, it might be a space occupying primary lesion or a METS. And if it's a vascular, perform angio. And do not forget, giant cell arthritis can walk in with a headache and a diplopia, and sooner it might eventually pass on to an arthritic anterior ischemic optic neuropathy. Please do remember that. And as I said, steroids is the mainstay of treatment, but rule out an infection, and radiotherapy has its role in refractile cases. And if it's an infective association, do not, be very judicious on steroids. Just inch it by with an antibiotics, be it an antifungal. And in our group of patients, we have a lot of tuberculous patients coming up like this. So we may have to give an antituberculous cover also. I'm just going to go through a few cases, whatever is permissible in this time. So this is a 65-year-old male who is walking in with diabetes and hypertension history with 3 weeks onset left 6th nerve palsy. But after the diplopia, he suddenly developed a drop in vision for which he has come. And CT brain done elsewhere was normal. So his vision was 612 in the left eye, but when we repeated the imaging, he had a lesion in the cavernous sinus which was almost entering into the superior orbital fissure. So 3 weeks back, diplopia turned into a vision loss by the time he came to us. And already there was a CT which was normal. So with a judicious use of steroids, he recovered. And this is a 23-year-old guy who had a history of headache with diplopia and ptosis following a zoster infection. You can see the scars on his forehead and the nose. He developed a sudden redness, and after which he developed a movement restriction and a vision loss, and we found a lesion in the cavernous sinus, and that guy responded well with antivirals. So as I said, TB is something which we have to watch out in our part of the world. So this guy, he had a previous history of a recurrent uveitis for which he had the vision loss. So his vision loss was because of a posterior uveitic entity, but he came with a left sixth nerve with a marginal lesion in the cavernous sinus. So with a watch, he recovered. He had already finished a course of tuberculous therapy. He was on steroids by the time we saw, and this is between 3 to 4 months. His lesion in the left cavernous sinus resolved, but he boomeranged again, coming with right third nerve. This was almost 6 months later, and pupil sparing right third nerve is what he came back, and this time the lesion was sitting in the right side cavernous sinus. So at that time we repeated all the TB investigations. Everything was positive. We didn't have a choice. We had to give her again a cover of ATT with a steroid, and that's when he settled down. And this is a guy who came with a sudden drop in vision with a frozen globe. He started with diplopia, but when I saw it was a frozen globe almost with a red and congested eye, and when we imaged, we had an extensive lesion sitting in the sinuses, nasal cavity, cavernous sinus, orbital apex, everywhere. And then he said that he had some ENT procedure for the maxilla, following which he has developed this. But unfortunately, there were a lot of lesions in the sinus cavity, which I requested the ENT person to go ahead and get an antral washing and a biopsy done, and it turned out to be aspergillus. So watch out in a poorly controlled diabetic, a fungal lesion. And there were era of fungal lesions even before COVID, because we all are smitten by the rhino-orbital mucar, but there are so much of fungal lesions even before that, because we have a high index of diabetic population in our country. And this is a 41-year-old female who was referred to me as a thyroid eye disease, and she had a history of squint and ptosis over a period of 2 years. And she had a previous imaging of CT orbit, which was normal, and her visual acuity in the right eye was 618 N8, and that of the left was normal, and she had a relative afferent defect in the right eye and a mild disc pallor in the right eye. So how many of you would agree that this is a thyroid eye disease? What do you see in this photograph? So it's a quiet eye. Maybe there's a mild ptosis in the right eye. So what's happening here? There's adduction restriction, elevation restriction, and depression, but abduction is fine. But along with that, what do you see? What is obvious in this photograph and in this? Brilliant. So that's a sign of aberrant third nerve regeneration, which means the third nerve is going this compression for a longer period of time, and that is not a thyroid eye disease sign. So I asked her, you may have to go for a repeat imaging, and she had this also in addition. So one more clue. What do you see in this? Is this feels normal? Okay, this is definitely black and something bad. What is this? Partly black. So what do you think it is? Where is the level of lesion? Something is abnormal, isn't it? So you could see a superotemporal defect in the left eye, which is the 6-6 eye, and this is an advanced field loss with a dense temporal. So definitely this is not a normal condition or a thyroid. So unfortunately she had a CT orbit which was normal. If they would have just pushed the cuts up, they would have picked this lesion long back. And that is an MRI which showed a huge suprasellar pituitary mass, and that's the reason why she had a multiple cranial nerve palsy with a vision loss, and that's post-tumor excision, her improvement of the visual fields. So this is a 10-year-old female who was referred to us with complaints. In fact, this patient was referred by an interventional neurologist who said that the patient has come back with a sudden drop in vision in the right eye for 10 days. And we just did a CCF management 2 months back. We had done an endovascular coiling for this kid. So this was the picture what he shared with me. It's a clinical acute subacute proptosis in the left eye where you could see, and she had recovered very well after the endovascular coiling. But now she has come back to us with a sudden drop in vision and a diplopia. And her vision in the left eye was 612, and fairly the disc was having only a subtle temporal pallor. And you could see that there's a complete EOM restriction in all direction in the left eye. When we repeated the imaging, we picked up that close to the vascularized coil, there was a saccular outpouching of the ICA. So there was a huge saccular aneurysm of the left ICA, and that has been compressing over, and this image MRA is confirming that it had a huge lesion which is extending into the superior orbital fissure, and that's the reason why she developed after 2 months of the treatment, a sudden diplopia. And the interventional radiologists, they just opted because they wanted to wait for a while, go for a course of steroid, and then probably they will take up. But she responded well with a course of steroid therapy, but still she is under our follow-up. So this is the course of thing what went through. CCF managed well, recovered, but then subsequently she developed a thing. And as the previous speakers have already highlighted, oculomyasthenia gravis is a great mimicker. So it can happen in any form, so watch out for that. We also did a short case series of our group of people where we found that most of them were unilateral, inflammatory condition, infective, followed by metastasis and tumor. And yes, neoplasm also was high in younger individuals, and cavernous sinus lesion was filled mostly with neoplasm, and superior orbital fissure invariably had inflammatory lesions. And younger individuals had neoplasm, and middle to older group individuals had more of inflammatory etiologies. So to summarize, orbital apex syndrome can present with even an isolated cranial neuropathy, but watch for optic nerve function test because we can't miss it if it is going to be not assessed. So neoplasms are common in young individuals and inflammatory diseases in older age. They do respond well to treatment, and we need a multidisciplinary management for these conditions. Steroids can be used judiciously, but be careful in poor control diabetic. Watch out for infections which are coexisting, and definitely an ophthalmologist plays a good role in these sort of diseases, and we need a multidisciplinary approach in controlling them and conquering this no man's land. Thank you so much.
Thank you so much, Dr. Ambika, for those lovely cases, which we expect